Right, ladies and gentlemen, thank you very much for coming. Sorry for the very slightly late start. You've probably seen me running around like a sheepdog trying to round everybody up. But we've got audience, fantastic, and I think we've got 2 out of the 3 speakers. We've got 3 out of 3 speakers, that's fantastic. So we'll start. Again, we'll probably take all the questions right at the very end, if that's okay, unless anybody's got anything burning to say throughout the end of each individual talk. We'll start with Joel Dunnings, well known to everybody, consultant up in Middlesbrough. His bio he's done for himself is at the top here. So without further ado, Joel, thank you. The evidence base for left atrial appendage closure.
Never be afraid of self-publicism, hey? So thanks for the invitation. Thank you, everybody. And I'm going to go through the evidence for left atrial appendage exclusion. This is a part of a guideline we wrote. I'm part of the guidelines war between all the journals where we try and bang out as many as we can. And we did do one on surgical treatment of atrial fibrillation. We couldn't cover absolutely every topic. We steered slightly clear of lesion lines, but we did look at a few areas. One area we looked at was the interesting issue of warfarinization or not after successful ablation. And another area we looked very carefully at was left atrial appendage, whether to close it or not. It's free full text online, so there's my advert. So it seems easy, doesn't it? It's just a little tiny appendage waving at you. Let's just take it off. You know, you get to put graft plus other. You know, you get some extra Euroscore points maybe, and it's the simplest thing. And you can say to that patient, I have protected you from stroke. So it just seems so easy. But there's a major warning, and unless you look at it properly, you're going to get this wrong. The successive exclusion in multiple studies, and I'm going to try and show you all the studies we found for our European guidelines and show you all of them to try and prove the points I'm making. The successive exclusion in multiple studies is 50 to 70%, not 95%, not 97%. If you don't close it properly, 50% of what you don't close properly will have a thrombus, and out of those thrombuses, half of those will cause strokes. Now that's quite frightening if the number needed to treat to prevent a stroke is 1 in 30, which is what it is. So if you're causing large amounts of bad exclusions, you're going to cause more strokes than you save. Now, this is what you have to think about before you close an appendage. First of all, you've got to know the evidence for stroke and AF, and we did a lot of that this morning. You've got to know how your nearest competitor, which is warfarin, functions and performs for stroke reduction. You've then got to know how well we can close the appendage, and also, does it cause stroke? Let's just review the evidence of that. Can you close it properly? And is there any evidence out there that actually what you're doing is going to reduce stroke rather than just an impression? So let's take the evidence for stroke and AF. Well, it's been nicely and eloquently told this morning that the Framingham study, beautiful study, 5,000 people, 34 years follow-up, and if you had atrial fibrillation in the older age groups, you had a 5 times increased risk of stroke. So yes, atrial fibrillation does increase your risk of stroke. Tick, we know that. Second, does warfarin, and how well does warfarin reduce that risk of stroke? Again, the stroke prevention in AF study, this meta-analysis by Gregory Albers in 2001 totally nails how well warfarin performs. So it reduces by about 60% your risk of stroke if you have warfarin versus not warfarin. But the interesting thing I'd like to turn your attention to is here's the control group. It's about 5% your annualized risk of stroke, and it goes down to about 2 or 3%. So the number needed to treat with warfarin is 30 per year to prevent a stroke. That's the sort of thing you're trying to get up to if you're closing the appendage and stopping warfarin. Do left atrial thrombi cause stroke and atrial fibrillation? So I'll just go through these 3 papers. This is perhaps one of the most misquoted papers in AF literature, if not all literature. Joseph Blackshear did a review of papers that looked at where clots were in the appendage. They included post-mortem studies, echo studies, small little studies. It was not a prospective study of themselves, and it did not look at all at where these strokes went. All it was look at the left atrial appendage, has it got stroke in it? The important finding from this is 1,200 patients that didn't have rheumatic fever, 200 had a stroke had a clot in their left atrial appendage, of which only 11 were not in the appendage. What they did not show is that they fly off and cause all the strokes. This gets misquoted as 90% of all strokes in patients with AF are caused by that stroke that's in the appendage. That's not true. It just means that there are a lot of thrombi in the appendage. There's a big difference there. And I'll show you in the next slides why that's important. And of course, a lot of the rheumatics, only 50% were in the appendage. So let's look at some other studies. The Stroke Prevention in AF study looked really closely at where strokes were coming from. They did TOEs, 4,000 patients, really good. 50% were probably from the left atrium, but 50%, 25 to 50%, were not. So about half of the strokes, or quarter or half, are not coming from the strokes in the left atrial appendage. They're coming from elsewhere. Now, warfarin's fine because it's treating that predisposition from other things, but just stapling your appendage does not. Obviously, and I didn't review it here, but there's quite a lot of evidence that AF in itself is a procoagulant state, which warfarin treats, and appendage stapling and stopping the warfarin does not. Here's another study that says, looks for where these strokes are coming from. Yep, 50% might be coming from the left atrium, of which 90% are in the appendage, but another 50% could all be coming from here. And you'd all echo this. I mean, your patients that you staple this appendage on, I bet loads have got calcified aortas, they've got carotid disease, and you might even find a few other rare causes. So the reason I put this up, as I say, is warfarin treats this, appendage stapling does not. So do left atrial appendages cause stroke? Well, 90% or less, that's the highest number that could possibly cause them. 50% may not be from the appendage. And at any one time, most of our patients don't actually walk around with thrombus, which may be a common misconception amongst the public. Now, how well can we remove the appendage? This should be easy, shouldn't it? Well, repeatedly, people show really bad results from this. This is Eugene Crystal's study, where he was performing a randomized study in it, the ELEOS trial from Canada. It was a pilot study. They wanted to do 2-to-1 randomization, but they had a terrible ability to actually close the appendage. You'd be shocked by this, but this is in a randomized study. Only 45% success with suturing and only 70% by stapling. What's the definition? Well, obviously, if you staple it, it's leaving less than a centimetre stump on TOE, and if it's suturing, it's leaving a space so that you can see some flow still in the appendage. But that is really bad. Remember, number needed treats 30 to do any good, and these are very high risk of getting strokes. Are they the only ones? Did they muck it up? Just of note, the LEOS study, there's going to be a LEOS 3 study. They just produced their protocol, 4,700 patients. They're going to randomise for appendage removal or not. They've published their protocol. I don't know how they get 4,007 patients, but good luck to them. It'll be an amazing study. Let's have a look elsewhere. Maybe it's just because, Canada. Well, no, the Cleveland Clinic, Mark Gillenoff's group, this was his cardiologist. When people came back and did a TOE, they reviewed the findings of the left atrial appendage, and they found in over 11 years, 137 patients they just randomly did TOEs for, not looking at the appendage. When they looked at them, the success was only 73% for excision. Suturing was horrific. Stapling, none of them were satisfied the less than 1 centimetre stump. And if they weren't done properly, nearly half actually had physical clot in at that moment. That's in the Cleveland Clinic. Ed Katz from New York, similarly, they had a look at their success, 64%, and of those that weren't successfully closed, 50% contained thrombus. And in that one, that was the one that showed that in those people that did have some thrombus in it, 4 of 9 actually had a stroke. Really shocking data, really. Are there other groups? Yes, Hans Sievers from Germany, same thing. Incomplete closures and thrombus in the atrium. A case report from Turkey. A 71-year-old. You've actually got a beautiful picture here. There it is. It's got, because actually here's all your sutures. So you can obviously see that maybe is a bit prothrombogenic. So yep, the INR was 2.7, and yet still, perhaps they postulated because of the suture, a thrombus appeared. So just because you're closing it, it doesn't mean you stop thrombus occurring. Mark Gilinoff changed his techniques. He tried to change what he was doing and produced another paper to try and sort of show an improved technique, knowing what he knew before. 10% still needed sutures for tearing, and they still got 5 strokes in that group. Remember, we're trying to prevent strokes here by doing this. So, in summary, the success of exclusion, there's one more way. It does show that you can do it fairly well if you concentrate on it. So it's not impossible to do it, and Anton Moritz showed that. So in conclusion on the success, you have to be sure you've closed it. You need a TOE afterwards. You need to make sure that if you've stapled it, there's less than a centimetre stump on TOE. And if you've oversewed it, there is a huge number of small holes that appear. Even in 2-layered, 4-0 Prolene, 2-layered closure. That's what the Cleveland Clinic was doing. They were still finding gaps in it. And a small, slow area of blood stuck behind suture is just sitting there ready to be a thrombus. So that's slightly worrying. Right, now, can we actually reduce stroke if we exclude the left atrial appendage? You'd think this would be obvious, wouldn't you? But actually it's not. Now, Jim Cox earlier said, well, you know, my 15 years study, there was 1 stroke in the whole study. I mean, that's barn door reason to take off the appendage. But let's just remember, the reason he was doing it was for symptomatic benefit. There was big operations. There were younger patients, a lot of low CHAD score patients. And the most important thing is the results were phenomenal. Most patients were in sinus rhythm. When he said he had a few failures, they were tiny numbers. And he was regarding a failure as like a single episode of AF, which they cardioverted. Most of his patients were in sinus rhythm. So I don't think you can really quote this as evidence for taking off the appendage, because they were all in sinus rhythm and they were young and had low CHAD score on the whole. Are there any other papers we can look to then if that's not good? Soufiane Alma looked at 136 patients that he'd excluded the appendage. There was a 12% incidence of thrombi in the group that they'd been excluded if they'd had warfarin, but it was 15% not on warfarin and 10 on warfarin. So actually, even though they're 12%, still you got an increased rate of stroke if you were not on warfarin compared to warfarin. So warfarin's still playing an important role, and therefore taking off the appendage is not the whole story. Here's a study by Brian Anderson in the Mayo Clinic where actually there was a correlation between LA ligation and increased risk of stroke, not reduction in stroke. So this was actually evidence the other way, therefore it doesn't get quoted very often. This study from Spain by Jacobo Silva, there was 205 patients, and this did give a little bit of evidence for maybe some benefit, 17 versus 3% if you ligated it. But they did still do 10% of incomplete ligations, and it's small numbers. Otto Alfieri produced this study. He produced a randomized study in this, 43 patients during mitral surgery. Now, 18 had successful LA exclusion. That's quite small numbers. Of note, interestingly, that while they randomized, 3 weren't randomized to the exclusion arm as the surgeon forgot to close the appendage before ending the operation. 1 person each got a TIA, so it didn't show any benefit in closing the appendage. So really, that's it apart from this. Now, this is the worst paper in the surgical literature in cardiac surgery, I think. It's the worst because this title has been quoted so many times, and I'm sure half of you who've done presentations have put that on their slides and said, there you go, it's our most lethal attachment. Dudley Johnson has proven it. Well, he certainly told us it was the most lethal. He certainly did not prove it. You really have got to read this paper. It's got 20 goats in it. It's 4 pages long, one of which is the references. It is 437 patients. There are 7 lone endoscopic techniques. There's a mishmash of everything, and there was no follow-up. There's no mention of how they followed up, what they did, whether or not they really looked to see if people got strokes or not. And then they said, well, you know, if I chopped off the appendage, 21 had strokes, but none of them were from the left atrium. But they didn't do any TOEs on that. So this is a study of goats and lone AF and all sorts of mishmash. It is not a study that proves that left atrial appendage exclusion can safely reduce your stroke risk and allow you to come off warfarin. So, slightly worrying, isn't it? The evidence for stroke risk reduction isn't there at all. There is no surgical study that says it's safe to stop warfarin in patients with LA exclusion. There's actually none that's even been sort of tried. So, what else have we got? Can we look elsewhere? Well, we can look to our cardiologists, who tend to do studies better than us, don't they? They've got these great gadgets, and they've actually looked into them very well, sort of assisted by their industry colleagues, and they've done some great studies. The Protect AF study for the Watchman device was a very well conducted study. As you all know, they closed the left atrial appendage with a Watchman device. It has a few technical differences to closure the way we do it, or the way Sasha Salzberg will be telling you how to do it, because it's got a raw area, so they're on warfarin for 3 months post-operatively. I won't show you that, you've probably seen it ages anyway, lots of times before. But here's their findings. It was a big study, 59 centres, 463 Watchman insertions. They all had a CHAD score of 2 or more, and they had good findings. It was criticised quite a lot because of the high procedural complication rate, but really taking them off warfarin 3 months after the insertion, you had the same stroke risk. And they've followed this up with a registry which showed that their procedural effects were down a little bit. And then they've interestingly followed it up with the Prevail randomized study. They wanted to do it again because they felt a bit embarrassed about their procedural complications. Now, here's a really interesting study about it. In current modern practice, you're down to 0.7% per year stroke risk if you use current modern medicine. So remember all the way back in that SPAF meta-analysis where it was at sort of 3% or so with warfarin. We're now down to 0.7% risk of a stroke per year. So they really are getting very low. And actually, they didn't meet all their primary endpoints because actually the controls weren't having very many strokes, really. So they did show that putting a Watchman device, you could safely remove the warfarin after 3 months of warfarin. So this is the only study that says closing off the appendage does reduce your stroke risk, although it isn't in a surgical cohort, although you can extrapolate. Sasha Salzberg is going to tell you about the fabulous gamut of surgical devices that can address that getting the appendage closed properly issue. Hopefully LAOS 3 will be able to address the issue of whether the evidence is there and whether we can reduce stroke risk. But just remember the evidence to date right now is that warfarin can reduce it by 60%. Half the strokes, maybe not 90%, come from the left atrium. So get that right, and that really you have to treat 30 patients to fix a stroke. So you've really, if you're going to close it, you've got to confirm it by TOE, whatever method you use. And if your complication rate on placing it is more than 1 in 30, you're going to cause strokes. So remember that you've got to do it properly. So I'd like to say thank you to Sasha Salzberg. He provided me a lot of data with this as well. And thank you to everybody here. And just remember, do it safely and do it properly and not willy-nilly. Thank you very much.
Thanks, Joel.
Well, I'm a warm-up hat for Dr. Salzberg.
Just shows that designing the trials is key and critical, doesn't it? So without further ado...
And reading papers is critical, because the lethal attachment paper, you've just got to read it. It's awful. But interesting how publicity can change things. Thank you.